Welcome to the Great Birth Rebellion podcast. I'm your host, Dr. Melanie Jackson. I'm a clinical and research midwife with my PhD, and each episode I cast a critical eye over current maternity care practice by grappling with research and historical knowledge to help you get the best out of your pregnancy, birth, and postpartum journey. To get access to all the research that I use to create every single podcast episode, you can join the mailing list at melaniethemidwife.com. Welcome to today's episode of the Great Birth Rebellion podcast. We're here with Dr. Sarah Buckley, who is a friend and previous guest of this podcast, and she's back today to discuss the interaction that occurs in the brain through to the body during labour, with specific reference to oxytocin. Dr. Sarah Buckley is trained as a GP with qualifications in GP obstetrics. She's been writing and lecturing to childbirth professionals and parents since 1997 and is the author of the international best-selling book, Gentle Birth, Gentle Mothering. Sarah has a special interest in the hormones of physiological labour and birth and the impacts of interventions. She's currently writing a PhD at the University of Queensland, researching oxytocin in labour and birth and the impacts of maternity care interventions on oxytocin. Sarah will also be joining us at the Convergence of Rebellious Midwives conference in Sydney in August, which is happening 2024. And if you're listening later, please know that the Convergence of Rebellious Midwives will be a reoccurring event and conference happening every year. Sarah is an invited speaker to the 2024 event and will be sharing with us some of the findings of her PhD. Sarah has co-authored several papers on oxytocin in labour and birth and breastfeeding and is the author of the 2015 report, Hormonal Physiology of Childbirth. If you're part of the mailing list for this podcast, those are all in the resource folders which you have access to. Sarah is also the mother of 4 adult children who were all born at home, and she lives on the semi-rural outskirts of Brisbane here in Australia. Welcome, Sarah. Thank you for being here again in the podcast because you've been with us here before.
Thanks, Melanie. It's a pleasure.
You've been very busy doing a PhD, so I'm grateful that you've given us some of your time. I want to kick off with a first question. In one of your papers that you published in 2020, you referred to birth as a neuropsychosocial event. Can you explain what you mean by that?
Yes. So my PhD is studying oxytocin and childbirth. So I'm looking at everything at the moment through the oxytocin filter. So if we say neuropsychosocial, I mean the neuro is to do with what's happening in the brain and these neurohormones, which is oxytocin is the one that I'm really focused on at the moment, but we can talk about some other neurohormones as well. So birth is a neurohormonal event. Things are happening. In fact, most of these hormones are being released from the brain into the body, but also into the brain. When people talk about oxytocin in the context of birth, they're mainly talking about it as the hormone that makes a fast, oxybirth-tocin, so as a hormone that makes the uterus contract. But what we've discovered in the 100 years or so since that was first discovered by a researcher called Sir Henry Dale was that oxytocin is a very powerful neurohormone as well, outside of birth, but inside of birth as well. So oxytocin is not just facilitating the physical processes of labour and birth, but it's sculpting the female brain. And this is every mammal, like oxytocin is a mammalian hormone, but it's sculpting the female brain to optimise survival during labour and birth, but particularly survival afterwards. So it's switching on all those, we call them maternal circuits in the brain that will mean that the new mother will give her offspring the dedicated care that every mammalian newborn needs, because as mammals, we have mammary glands, we suckle our young, and all of our babies are born in an immature state. They need nurture, they need protection. So all of these the neurohormonal aspects of labour and birth are designed to help the mother through the processes of labour and birth, but particularly to ensure survival of the species, basically by sculpting the mother's brain to optimise the dedicated care she's going to give to her newborn. So that's the kind of neurohormonal aspect of it. So the psychological aspect of it, well, I guess we've got to look at women for that, because we can only guess what's happening in the animal's brain, which is actually where most of the research is being done. But these neurohormones are made in what's called the limbic system, the middle layer of the brain. Oxytocin's made in the hypothalamus and then stored in the pituitary, released into the body, but at the same time released into the brain. And the limbic system is sometimes called the emotional brain. So it basically has major functions on our emotions. And if you were to Google oxytocin, you'd find out all of that. It's the hormone of love, hormone of monogamy. It's a feel-good hormone. And all of these things are happening in the mother's brain during labor and birth. So it's an anti-stress hormone. So oxytocin specifically within the brain, it's released from the brain into the body, but then it's released in quite a widespread way into the brain. And within the brain, it's called a neuromodulator. It modulates the function of lots of aspects of the brain. So it modulates the function of the amygdala, the fear center. So when oxytocin levels are high, it dampens down our sense of fear. And in all mammals, it's actually a social affiliative hormone. It increases our social connectedness, our desire for social interactions, which is interesting in labor and birth, right? We often seek out people to support us, and that's true of all mammals. Dogs, cats, elephants, most of them give birth within a social group, or at least have one other member of their social group attending them. So it's a social affiliative hormone. It reduces fear, but also it does a very powerful damping down of the stress system. And something we found in a different paper, which was a paper we did on oxytocin levels during breastfeeding. And there was a beautiful study that measured oxytocin levels during breastfeeding, but also cortisol levels. And they were like mirror images of each other as oxytocin went up, as it does during breastfeeding. It's the milk ejection, the letdown reflex hormone. Cortisol levels went down. And it does this actually through central effects in the brain. And that dampens down that medium-term stress response. But it also dampens down the short-term stress response, which is the sympathetic nervous system. So it rebalances what we call the autonomic nervous system. This is a lot of detail, right? So it rebalances the autonomic nervous system. So the autonomic nervous system is like the automatic nervous system. So it's the part of our nervous system we don't think about. It's regulating our skin temperature, our blood pressure, our heart rate, our gut, all of those kind of organ functions. And it's in a balance between the sympathetic, the fight or flight, or even the activating, like we're sitting here upright, we're alert, I'm alert. My sympathetic nervous system is active in my brain. But when we lie down, when we relax, when we go to sleep, then our parasympathetic takes hold. That's the rest and digest, calm and connection system. So when we get a surge of oxytocin in the brain, it increases the parasympathetic and decreases the sympathetic. And we can measure that, for example, by blood flow to the skin. When we're in the parasympathetic, we literally become warm. We become a warm person. Yeah, we lose our cold feet. And people have actually used this as a measurement. So specifically in labor and birth, when we optimize the balance or increase the parasympathetic, reduce the sympathetic, that in itself optimizes the function of our contractions as well. But at the same time, it gives us this psychological damping down of stress. It helps us to deal with the intensity of labor and birth. Imagine an animal, that doesn't know anything about labor and birth, hasn't been to classes, right? So, when labor and birth starts, they could get freaked out. They could get aversive. They could try and run away. But oxytocin's there really to help them to deal with this, to calm, to settle down. Lots of animals are quite quiet in labor and birth. If you've had a dog or a cat or something give birth, they often lie down. You kind of stroke them, increase their oxytocin, help them to feel safe. And all of those things are kind of psychological, helping the laboring woman to cope with the stress and intensity of labor and birth. And the other part of it is that oxytocin powerfully within the brain switches on the pleasure and reward centers. So this is the dopamine pathways in the brain. And again, this goes back to what optimizes survival in the wild, why we're all here today. So there's peaks of oxytocin or the increased levels as labor progresses. And I think the paper you're referring to, the physiology paper, the 2019 oxytocin levels in physiological birth. So in that paper, what we showed was that from the beginning of labor to the end of labor, oxytocin levels as measured in the laboring woman's blood increased by 3 to 4 times. And there's a whole lot of caveats about that. It's quite hard to measure in laboring women. It's released in pulses. centimeters, but generally what we found was 3 to 4 times higher. So measuring in the blood, obviously we can't measure it in the brain, but this increase in oxytocin as labor progresses is helping the laboring female not just to feel good and to feel calm, but actually literally switching on all those pleasure and reward circuits in preparation for meeting her babies, because that's the pivotal moment of species survival. She has to have a positive feeling towards her baby. She has to be rewarded and motivated to give that dedicated care that every mammalian mother gives to her newborn baby. So literally within the brain, we talk about firing and wiring, two parts of the brain active together. So we have the reward and pleasure centers maximally activated at that moment of birth as the mother's pushing her babies out. In that pushing stage, we get these huge peaks of oxytocin, probably too high than we could ever possibly measure. You have to measure every 30 seconds to measure those pulses, right? So these huge peaks of oxytocin in the bloodstream, but obviously in the brain, maximally activating all of those pleasure and reward centers, so that those pleasure and reward centers are activated. Then the new mother gets those sensory input from her baby. She gets the sight of them. She gets the smell of them. She gets to taste them. Most animals lick their babies, right? She gets the physical contact with them, and all of those things get literally fired and wired with these peak activation of the pleasure and reward centers. And from the very beginning, those babies are a source of pleasure and reward to her. And for example, some animal studies have shown that for this window, this first, I think in the rat, it was 12 days, maybe 10 days after birth, the mother is more rewarded. She prefers contact with her babies to cocaine, which is incredibly rewarding, right? So that's how rewarding the babies have to be, to make sure that every mammalian mother is going to give that dedicated care, because, it's not enough just to have a successful birth or even successful lactation, but if the mother doesn't take care of the babies don't survive. And we kind of forget in humans that's also hardwired into our systems, into our brains, into our physiology, into our neurochemistry, into our neuropsychosocial process of labor and birth, is that activation of pleasure and reward centers. So, I wrote a book called Ecstatic Birth, Nature's Hormonal Blueprint for Labor. And that is actually what's designed to happen, that we have this rush of incredible reward and pleasure center activation, euphoria, ecstasy, pleasure for that contact with our babies. And that's what's going to ensure the survival of the species. So, it's not just a good feeling when you get that maximal activation in physiological labor and birth. It's actually about survival of the species. So we've talked about neuro, we've talked about psycho and social. Well, it kind of fits in with all of those things, really. And as I mentioned, birth is generally a social activity in all other mammals. And that is also for survival reasons. Like imagine, well, if any of the listeners have been in labor or attended labor, a laboring female is not very able to defend herself, to protect herself in the wild. So we need structures, we need processes that protect us in the wild from predators, because any laboring female is behaving a bit oddly in the wild that would attract predators. The strange noises, strange smells, the blood, the amniotic fluid, the baby that comes out at the end, all of these things would attract predators. So that the safety system for the mammalian mother includes those social aspects of labor and birth. So an elephant, for example, gives birth surrounded by female members of her social group, and they sway in time with the laboring elephant, apparently, and soothe her with their trunks. And dolphins, there's a dolphin midwife often present at the birth that helps the baby, nudges the baby to the surface to take her first breath. Mice often have another female helper who licks the newborn babies, bites through the cords, maybe even eats a placenta or two. So most mammals do have some kind of social protective system around them in labor and birth in the wild. And we're designed for that as well. We're designed, as I said, oxytocin is a social affiliative hormone. So we're kind of designed to seek social support. I mean, people say midwifery is the oldest profession, right? It's no accident, because we're designed to seek this social support. And yes, some species do give birth a little more solitary, but most of them generally have a helper with them. And I think women are like mammals. Like some of us like to be more solitary birthers, some of us like to be more social birthers, but no mammal would go out in the wild by themselves and give birth by themselves, because it wouldn't be a safe thing to do, right? So neuro, psychosocial, all of that is hardwired into our biology as humans, as members of the mammalian family in giving birth.
So the oxytocin flow starts from the brain. and then moves down into the body to act on so many things. Is there any oxytocin production in the body?
There is some oxytocin produced within the uterus, like the amnion, the chorion produce a bit of oxytocin, but that is a local effect. Yeah, it's called paracrine. It's a paracrine hormonal effect where oxytocin is produced pretty much next door to where the receptors are. So it's happening very locally. That's not the kind of thing that generally shows up in the bloodstream. So yeah, when we measure it in the bloodstream, it's generally coming from the brain. But within the uterine muscle, goodness me, there's so much happening in the lead up to labor and birth, and so much paracrine local effects. We've got prostaglandins happening, we've got inflammation happening, all of these things. And it's interesting, Melanie, like when we looked at these studies, what we called systematic reviews, we looked at oxytocin levels in physiological labor and birth, oxytocin levels in breastfeeding, oxytocin levels in birth with synthetic oxytocin. I'm actually just working on one, oxytocin levels in cesarean, and then the next one is oxytocin levels in birth with epidurals. So this systematic methodology, basically we cast a wide net through all the studies that have been published, and we gather them together. In some systematic reviews, you can kind of pool and analyze together all of the information, but we couldn't do that because the studies were so different. But generally what we could do was summarize and make all authoritative pronouncements about oxytocin in these circumstances because we had all the literature there. And it's interesting because some of the earlier studies of oxytocin, which by the way were actually the best, they used like excellent methodology, the very good studies, but they first started studying oxytocin because they thought it was oxytocin that caused labor to start. But it's actually not that. And if I could tell you what it is that causes the physiological onset of labor, I would get a Nobel Prize, right? Because if we understood that, we'd understand and have mechanisms to prevent like preterm birth. So, but we don't know that. So oxytocin's part of the process. There's all these paracrine or local events like prostaglandins. Inflammation is happening as well. But what we can say about that from an overall perspective is the onset of labor has to be like exquisitely orchestrated, perfectly orchestrated between the mother and the baby, right? The mother has to be ready for all of these processes that we just described for the most successful labor and birth. But the baby has to be ready as well because the baby is making this incredible, miraculous transition from life inside the womb to life outside the womb. So the baby's readiness is absolutely critical. So there's all these signals that get passed back and forth across the placenta between the mother and the baby. And one of those, no accident, is to do with oxytocin. We know that one of the things that happens is that the baby's adrenal gland on top of the kidney is maturing. And as it matures, it produces cortisol. That's where it comes from. And that cortisol is then going into the baby's bloodstream and helping to mature all the baby's organ systems. So cortisol is happening, but the baby's developing adrenal gland also produces a pre-hormone called DHEA, and that goes to the placenta, and that's made into estrogen, and that crosses into the mother, and it's estrogen that upregulates or activates the oxytocin system. So through that, you can see that as the baby's adrenal gland, the more mature it gets, the more ready it gets for birth, and the more ready it's making the mother's body for birth. And what's really interesting is that the readying of the mother's body through increased estrogen levels, which rises as the onset of labor gets closer, and the activation of the oxytocin system, is it's not just about oxytocin levels, it's actually about a whole lot of activation of the oxytocin system. And some of this includes what we call oxytocin receptors. You were saying before, the oxytocin from the brain going to the uterus. Well, the way that oxytocin actually works in the uterus is through these things that we call receptors, hormone receptors. That's how all hormones work, right there. A hormone is a substance that's produced in one part of the body with effects at another part, and it has effects by binding to these receptors, and it's like putting a key into a lock. So oxytocin released from the brain travels through the bloodstream, finds the receptors which are on the outside of the uterine muscle cells, and it binds to those like putting a key into a lock, turns the key, sends a chemical message into the cell saying contract. Now, we talked about oxytocin levels going up, and they actually do gradually increase as pregnancy progresses. More estrogen, more oxytocin, levels go up somewhat during pregnancy. But what actually happens is the mother's body becomes more sensitive to oxytocin because there's this increase also through estrogen and oxytocin receptors. So the more receptors you have, the more sensitive the body is. So you can imagine, if we want labor and birth to be as maximally effective and efficient for any animal in the wild, right, then we want not just more oxytocin, but we want more oxytocin receptors. And that's exactly what happens. It's actually been measured. You can look in my paper, in real live women, of oxytocin receptor numbers or density. And when we get to the lead up to labor, from before pregnancy, the numbers are about 1 to 2. By the lead up to labor, the numbers are about 1,000. So the pregnant woman's uterus, that just before the onset of labor, is like 1,000 times or 500 times more sensitive to oxytocin than she would be outside of pregnancy. And then at the onset of labor, it's about 3,000 times. So 3 times more sensitive at the onset of labor. And what we found was very interesting in our systematic review of oxytocin levels and physiological birth. They're all open access papers. You can read them, or you can go to my website, sarahbuckley.com, and click on all the science, and there's links to all of these open access papers. So what we found was at the onset of labor, women's oxytocin levels actually aren't that high. They're equivalent, if you work in a hospital or you've administered synthetic oxytocin, they're equivalent to a low dose of that, 4 to 6 milliunits per minute. So there's not a huge amount of oxytocin in the mother's bloodstream at the onset of labor. And it's not, going back to those studies, it's not what causes the onset of labor, because levels just aren't that high. But because of the sensitivity, the mother can have quite a strong reaction to that. And an anecdote about that. So I actually breastfed through my second pregnancy. And every day my toddler would come in, have a little suckle in the morning, fine. But the day I went into labor, she came in and had a suckle, and I had to literally throw her off because I got this massive contraction. So the day before, not that sensitivity. The day of labor, this incredible sensitivity to oxytocin. I had this upregulation, this increase in oxytocin receptor density. Also, the strength with which oxytocin binds to its receptor goes up. All of those things are really there to ensure that the labor is going to be as efficient and effective as possible. So just one more thing to say about that is, so the duration of labor is the duration of risk. The longer the labor is, the more likely that animal and their baby are to not survive, right, to be taken by a predator. So evolution, or Mother Nature, or whatever you want to call it, as I call it, Mother Nature's superb design, really designs labor and birth to be as maximally effective and efficient as possible, to be as short as possible during labor and birth, during the pushing stage. Obviously, it's a big job to get a baby out, any mammalian baby, right? So it's not over in a whisker for most mammals. But that process is as efficient as possible. And part of this efficiency is everything I've described, the increased estrogen, making sure that the baby is also ready through the cortisol from the adrenal gland, upregulating the mother's body. So she's got all these oxytocin receptors. And then when oxytocin starts at the onset of labor, she's going to have the most effective and fastest oxy birth tocin. Yeah.
We know there are things that can enhance the activity of the brain in labor, in its production of oxytocin and all the things that need to happen in the brain in order to act on the body. But are there impacts on oxytocin production in the brain? There must be a circumstance at some point where that functionality is impacted.
Yeah, good question, Melanie. So one more piece of the oxytocin picture, which is that once oxytocin starts in labor and birth, there's a positive feedback cycle that keeps it going. So oxytocin is designed to work in a particular way and to increase, I call it the snowball of labor. So it's not things that increase oxytocin, because oxytocin increases by itself. It's more avoiding things that disrupt it, as you say. So this positive feedback loop, you may know as the Ferguson reflex. So basically what's happening in labor is the baby's moving down, and the pressure of the baby on the lower vagina, the cervix, even from the very beginning of labor, the pressure gives sensations. You might have noticed that if you've had a baby yourself, it gives sensations. And the sensations actually feed back to the brain by a specific nerve pathway. Yeah, it's a parasympathetic nerve pathway up to the brain. And when that information of the sensations and the pressure gets to the brain, it tells the brain to release more oxytocin. So the brain releases more oxytocin into the brain, calming, connecting, pain relieving effects. I haven't mentioned that. Oxytocin has pain relieving effects in the brain. So all of those things that are going to help the labouring female to deal with the processes of labour and birth, but also released from the brain into the body. So it goes down, finds the uterine oxytocin receptors, binds to them, causes strong contractions, more sensations, more stronger contractions. So I call it the snowball of labour. It basically starts small, becomes bigger and bigger, and in the end becomes virtually unstoppable because of this positive feedback loop. So oxytocin, left to its own devices, or we could say when the labouring female is well supported in her environment, and we'll go back to feeling safe as well, then this oxytocin feedback loop will flow. And I think if we're talking about what optimizes or doesn't disrupt the oxytocin system, again, it's really helpful to go back to this evolutionary model. So any mammal giving birth in the wild has to be in the safest place possible. She's vulnerable to predators. She needs to know that she's in the safest place possible. And the way she knows that is by her subjective feelings about it. Yeah, there's no other test for safety, right? Does this feel like a safe place? And that's her sensory input. Does it smell safe? Does it look safe? Is there any rustle in the bushes of a potential predator? So it's interesting in labour and birth that the labouring female, she's sensitive to the sense of safety around her, yeah, and sensitive in terms of her senses. So her subjective sense of safety is critical. So if she doesn't feel safe, then it's not a safe place to have a baby, right? So it doesn't make sense for this oxytocin feedback loop to be going. So probably what happens is the initial lack of safety slows down oxytocin is probably the initial step. And then later on, if she still doesn't feel safe or something actually happens, then probably we think this, we don't know because we haven't sampled the brain in labouring women or labouring animals actually. Probably the second thing that happens is the fight or flight system kicks in, and then she needs to fight or flee to find a safe place. So both of those systems kick in if she's not feeling safe, and both of those systems will slow down or even stop labour. And women often have this experience, like they're labouring at home. Home is an ideal place where they feel safe. Familiar smells, familiar sights, near noises, and then they go into hospital. And look, no labouring mammal would ever go to such a strange place to give birth. Like, it's not safe from a limbic system sensory feedback perspective. So going to a hospital often slows down or even stops labour and birth, right? And then you have to settle in and feel safe and ideally have someone with you that helps you to feel safe. So not just a partner, but your own midwife ideally, or a doula that creates that sense of safety around you. And then once you start to feel safe, labour can start again. But, we haven't constructed our system of maternity care to help women feel safe. And when we do, for example, in home birth or birth centres or one-on-one midwifery care, or even taking a doula to hospital with you, then labour goes much better. It's shorter, there's less interventions. So all of those things because of the optimization and the lack of disruption of the oxytocin system.
What happens if women miss out on that oxytocin? It seems to be the key factor in that neuropsychosocial process. But there are a lot of women who miss out on that physiological event. What happens to their maternal instinct? Can you speak to the gap that occurs for those women?
So those are big questions. So yeah, you're talking about induction of labour, you're talking about cesareans. I mean, the other thing we'd have to mention is epidurals and synthetic oxytocin. So those are all common interventions in labour and birth. Almost most women will get one or more of all of those things. And all of those things can disrupt the oxytocin system. So let's start off with induction. So I think the thing with induction, again, it's interesting because if we go back to our kind of hormonal model of evolution and survival, I mentioned how important it is that the bonding happens, that the mothers are rewarded and motivated to give that dedicated care. So I talk about the triangle of species survival. I talk about successful labour and birth, obviously that's the foundation of survival, but also lactation. We're all mammals, we all suckle our young, and there's no natural alternative to lactation, right? If the mothers don't lactate, the babies don't survive. So successful labour and birth, successful lactation, but also, as I mentioned, successful maternal bonding to her babies. She has to be rewarded and motivated to give that dedicated care. You can give birth, you can lactate successfully, but if you just leave your babies there and don't protect them, then the babies don't survive. So all of those things, are equally critical for survival of the species. So they're equally hardwired into us. And it's a big limitation of our maternity care system that all we focus on is the birth part. We don't actually look at the outcomes of breastfeeding in many studies, and we don't often look at the outcomes of bonding. And, lactation's over there with the lactation consultants and the lactation journals, and bonding's over there with the psychologists, and it's not even mostly linked to labour and birth, right? Whereas that's so intrinsically biological. So these things haven't generally been well researched, and that's part of my PhD studies. So starting with induction for scheduled birth basically means that the mother isn't in that full state of readiness and the baby isn't in that full state of readiness. And to be honest, we haven't really researched that very well. Like we know, for example, in some animal species that the final touches on that, especially that maternal bonding system, only happen in the last hours of pregnancy. These are animals with short gestation, so I'm not saying the last hours in humans, but maybe the last days in humans as well. And remember, we talked about that upregulation, that increase in oxytocin receptors that happens from late pregnancy to the onset of labour, 3 times more sensitivity. And in humans, we don't know that, we can't predict for an individual woman when she's going to go into labour. We have this wide variation in physiological onset of labour from 37 weeks or 38 weeks up to 42 weeks. So we don't know when that woman's going to naturally go into labour. So we don't know when the peak of her oxytocin receptors is. So women have had the experience of being induced and nothing happens. They're just not at that optimal state of readiness. They could be 39 weeks, they could be 40 weeks, but still their body isn't ready. And thinking every woman should be ready to go into labour at this magical number of 40 weeks, it's a bit like saying every child should walk at exactly 12 months. It's like biology isn't like that. Biology has a variation. And if we go back to this principle that it actually originates in the baby, and that is generally held as the truth, that the baby is the one that triggers the processes and the onset of physiological labour and birth. Probably the mother determines the time of day, but the baby determines the day. So if we go back to that, then there's going to be a gap in the baby's readiness as well. And if you look on my website, I've got a blog about the ARRIVE trial, and there's also another blog about induction of labour. And some of the studies are now showing that children at earlier gestation do have some gaps in brain development because the brain's developing very quickly at the end of pregnancy. So basically if labour hasn't been initiated, then the baby by definition is not at full readiness, is not fully baked, and the mother isn't at full readiness either. I mean, we did this systematic review of oxytocin levels during labour with synthetic oxytocin, and we could say that when women are induced with synthetic oxytocin, they require higher doses than if they're augmented, if it's given to speed up labour, if they've started labour naturally. So the mother's system is more sensitive to oxytocin, as we would predict. But we don't really know what the hormonal gaps are in relation to induction, which is quite crazy when you think about it, of how many women are getting induced, especially first-time mothers. First-time mothers have a generally longer gestation, more like 41 weeks than 40 weeks. So they're particularly likely to get induced. So we don't actually know what the hormonal gaps are with induction. So that's induction. Okay. Let's go to synthetic oxytocin. And again, we've written a whole paper on this. So synthetic oxytocin has pros and cons. So before I did this paper and my earliest work on the hormonal physiology of labour, I thought that synthetic oxytocin was kind of like the devil. And a lot of people think that it causes harm. It could cause autism in children. It doesn't, by the way. You can read my blog on that. But, what we know is that synthetic oxytocin is given to increase the strength of contractions, that's called augmentation, or given to induce labour, often after the cervix has been ripened with prostaglandin. So it's given to most women who are induced and women whose labour is slowed down. Wonder why it's slowed down in a hospital setting, right? To speed labour up. So synthetic oxytocin is given into the body, so it doesn't cross into the brain. It doesn't cross the blood-brain barrier. I've got a lot to say about that in my paper. But when it's given into the body, it does increase the strength of contractions, but it doesn't give in parallel those calming, connecting, pain relieving effects. So you get a bit of a mismatch between the brain and the body. But on the other hand, the other thing about synthetic oxytocin is that it's basically overworking the uterus. It's like the uterus is a muscle, right? You go for a long run, your muscles get sore because you get lactic acid build up in them. There's not enough blood flow to clear all the lactic acid, and then you have a rest, and then your muscles get less sore and the lactic acid gets cleared. And that's basically what's happening during each contraction. The uterus is squeezing hard, the blood supply is compromised, lactic acid builds up, and as you can see in our paper, we actually think that the buildup of lactic acid is actually what causes a contraction to subside, and you have a break in the middle, and then the next contraction starts. So, and it answers a question I had. This is a little aside, but I always wondered why, if you give oxytocin, we didn't say this actually, is released from the pituitary in pulses, that I always thought one pulse causes one contraction, and that's where you get rhythmic contractions. But if you give a woman in labor synthetic oxytocin, you give it in a constant dose, she still gets episodic contractions. Why does that happen? And we think the reason for this is that the ebb and flow of contractions is actually probably controlled within the uterine muscle. The lactic acid buildup, probably a buildup of stress and pain and sympathetic nervous system, and then the contraction stops, and then you get this nice gap in the middle. The mother replenishes, the blood flow comes back into the uterine muscle, the lactic acid gets cleared out, the oxygen comes in, and then ready for another labor and ready for another contraction.
We spoke about physiological lulls or plateaus in labour on one of the podcast episodes with Dr. Marina Weckend, who's doing some research in that area. And it would make sense that the working muscle needs a rest, and the buildup of lactic acid creates that circumstance of rest. And that physiological plateau, it occurred to me, there could be quite a connection between physiological plateaus and the lactic acid buildup.
Yeah, that makes sense. I mean, basically, if you get a lactic acid buildup, the uterine muscle is not so contractible. Yeah, that's an interesting, So basically what's happened with synthetic oxytocin, it's overworking the muscle because it causes contractions that are stronger but also closer together. And that's probably the critical thing. So there's not that replenishment time in between for the uterine muscle, but critically for the baby as well, because every uterine contraction is squeezing the placenta and depriving the baby of blood and oxygen. It's a mammalian process. There's no way around that. There's only one way for the baby to come out, through these strong uterine contractions, and each one's going to squeeze the placenta and deprive the baby of blood and oxygen. But all mammals are superbly adapted to that. There's all these processes that protect the baby, that protect the baby's brain. But one of the most critical parts is that replenishment time between contractions. And that's what makes synthetic oxytocin dangerous for the baby. That's why if you're given synthetic oxytocin, you have to be monitored, because it actually can compromise the well-being of the baby through hypoxia, lack of blood and oxygen. And this is an animal study, so I'm sorry it's a bit cruel to the animals, but it was a sheep study where they actually got the baby in the womb, the lamb, and completely cut off the umbilical blood flow with a clamp. So the baby got no blood flow, and then they released it. And as long as there was a sufficient time, I think it was 2 minutes, for the replenishment, they could completely cut off the baby's blood supply. So it's not the actual strength of the contractions, probably, because they're going to get that strong at the end of labour anyway. It's probably to do with the replenishment. And in fact, clinically, this has been recognised. I think there's a magical number, which is 2.3. If there's not a 2.3 minute break between contractions, then there's more harm to the baby. So that's really important as well. So for the baby, for the mother's uterus, the replenishment in between is critical. And if that doesn't happen, the stress for the baby we've just described, and stress for the mother as well, like her uterine muscle just doesn't recover. It builds up lactic acid. Labour can even slow down at the end, and then you give more synthetic oxytocin. You're basically flogging the poor uterine muscle, right, in a very unkind and cruel way. And then we're expecting it to contract to prevent hemorrhage after the birth, and it can't do it because it's just bogged down. In fact, one interesting study, one research group have actually given a alkaline, I think it's just bicarbonate, sodium bicarbonate, which is an alkaline. And like some athletes do this apparently before a big event, they'll preload themselves with an alkaline, which reduces the lactic acid buildup. And actually, when they've done this, the labour processes is much better because it counteracts the lactic acid buildup, which is a very simple mechanism to help labour to continue and to go well. But ideally, if we go back to first principles, why do women need synthetic oxytocin? Because labour is slowing down, or it's not conforming to the straight line that we're meant to have, which again is not at all biological. I'm sure you've got a lot to say about that, Melanie. So, yeah, we're expecting labour to conform to something in particular, and, it doesn't conform to that, not surprisingly. So, yeah, because it's meant to conform to this, and also because we don't provide those circumstances for everything we've talked about. Michel Audin, the wonderful French surgeon and childbirth attendant, says that the basic needs of the labouring woman is to feel private and safe. And I say private, safe, and unobserved. And you can't suddenly put a woman in a hospital and she will naturally feel private and safe. And even if she intellectually thinks it's a safe place, she needs that limbic system. She needs that support. She needs that nurturing. She needs that protection, right? So often, especially first-time mama will go to the smallest room she can find, like the toilet or the shower, to give it birth, because that's where her limbic system knows that she's safe. So, I'm sure a lot of people would agree with me when I say that we wouldn't need very much synthetic oxytocin if we provided that physiological, psychosocial environment for birth. But one more thing I want to say about it, which is why I initially said it's not the devil that we thought it was, is that if you think about our positive feedback loop of labour, this positive feedback cycle depends on the strength of contraction. So the stronger the contraction, the more sensation, the more feedback to the brain, the more oxytocin release, the stronger contractions, right? So anything in labour that makes contractions stronger, if the mother's at the state of adequate readiness, like enough oxytocin receptors, oxytocin sensitivity, can speed up labour and can even increase oxytocin release into the brain. So in some circumstances, we think if synthetic oxytocin levels are not high enough to cause stress and all those things we just talked about, then it could actually indirectly increase oxytocin release within the brain because of that feedback loop, because of the stronger contractions. And I think personally, probably if that's happening later in labour, it's not so stressful. And also, this also depends on the absence of an epidural. So I could talk about epidurals in a minute, because that whole system gets very much disrupted by epidurals. But just to finish that synthetic oxytocin bit, so studies have actually shown that when women get a low dose of synthetic oxytocin in labour, it can actually increase what we call their maternal adaptations. So we talked about how the changes in the brain during labour and birth that optimise the mother to take care of her baby so everyone survives, right? So in women, some of these things have been measured. And one of the things that's been measured by my supervisor Kirsten Uvnas Moberg in Sweden and her colleagues is actually changes in personality. And this goes back to oxytocin as well. So you get these peaks of oxytocin at the end of labour and birth, and they actually sculpt the brain to change personality. So when women have been through physiological labour and birth, they report that they're more relaxed, less physical tension, less anxiety, more social, more seeking of social opportunities, all oxytocin effects. So that's physiological birth. And when women have had this kind of lowish doses of synthetic oxytocin, like a couple of studies have found more of these beneficial personality changes. So it may actually promote some of these maternal adaptations in the brain. I'm not saying we should all have it for that, because the differences weren't that great. But I guess what I'm saying is at a certain low dose level that just slightly increases the intensity of contractions, it's probably not harmful. And that's kind of where we came to. So some of the harm is if its levels are too high, it causes stress. If the interval for replenishment is not long enough for the mother, not long enough for the baby. And by the way, one of the things, and I've written about this, I'm writing about this in my cesarean paper, that I think we forget is that the first-time mothers have never had this before. And in all animal studies, first-time mothers are more vulnerable to disruption. So all of these things we've talked about, if you've had a baby before, it might or might not impact you so much. But first-time mothers are especially vulnerable and more prone to disruption. So my hypothesis would be that first-time mothers may be more, if they were induced, may not have that full brain activation that women who've had a baby before have, because they've walked this path before. They've got the brain pathways. They've had babies before. They've had that rush of pleasure, hopefully, with the physiological birth first up, right? So particularly, I'd say first-time mothers could could be more impacted by induction because of, well, we know that generally their labours are slower, all of those things with the first-time mothers. So I think induction is particularly problematic for first-time mothers. So women certainly could have that experience of not getting that whole download. And I've got to say, like, I've had 4 babies, right? And the more babies I have, the more download I got, like the more activation I got with each time, more pleasure and reward center activation, probably more oxytocin receptors in my brain. With my last baby, it was like, it was unbelievable. I had this, like, I felt like I'd won the lotto twice, honestly. I felt like I had this incredible experience. And then I had this beautiful baby. Like, how is that even possible? Was where my brain was at because of that enormous activation, probably because it had been there 3 times before.
So an epidural impacts what your brain does in labour. Can you explain how?
Yes. So if we go back to our positive feedback loop, and I wish I had a picture here, but again, I'll refer you to the epidural blog. So, just going back to it. So the sensation, the baby's coming down lower, the sensations of labor, feedback to the brain, increased brain oxytocin release within the brain, from the brain to the uterus, stronger contractions, more oxytocin release, right? That's our positive feedback loop, our Ferguson reflex. So the problem with epidurals is they're so effective at blocking pain. So because they block sensation, they basically slow down or even stop this positive feedback loop. And the positive feedback loop is not only increasing oxytocin in the blood, and we can measure that, like when people have an epidural, their oxytocin levels in the blood go down. But remember, it's increasing oxytocin in the brain as well. So that's kind of part of the problem. And we can do all kinds of things in animals we can't do in women, right? We can give an epidural and measure brain oxytocin. We can measure behavioral effects. And in sheep, for example, with epidurals, the chance of them bonding with their baby in the first half an hour, which is critical for sheep, and, is very disrupted in first-time mothers, less disrupted in subsequent and in reproductively experienced ewes, female sheep, yeah? And the other thing that they could measure is the brain oxytocin levels were lower, right? So it actually did affect the brain oxytocin through this positive feedback loop. And in one of those studies, they actually went back and injected oxytocin into the brain, and it mostly filled that, what we're calling hormonal gap. So the mothers then went and bonded with their baby. So yeah, we can't do it in women. There are some studies in women showing some restrictions in bonding. It's kind of a tricky thing to measure because what are the women getting that are not having the epidurals? Everyone's kind of medicalized these days, and are they getting induced? So there's so many factors involved. And I don't think we've ever looked at it from the kind of oxytocin lens that we're describing here. But yeah, generally with an epidural, blood levels go down, brain levels go down in all animals, so we presume in women as well. Women become more actually, I read this book in a bookstore one time called The Girlfriend's Guide to Pregnancy, and she described when women get an epidural, they become more nice and more friendly to their husbands and their companions, right? They become more normal. They lose that brain oxytocin, which is not just calming, connecting, pain relieving, but it's activating all of the opioids as well, like the endorphins in the brain, which are putting the laboring female, all mammals, into this altered state of consciousness. So you shut all that down as well, and women become more normal in labor. And I think it's kind of no accident women became more biddable. They become less wild, less a force of nature, as a laboring female is, right? They become easier for the hospital manage if women have an epidural, and easy for themselves too, right? Because it can be scary or frightening, and you're not in that circumstance where people expect you to take all your clothes off or make loud noises. But that's what helps women over millennia, helps all animals to deal with the stresses of labor and birth. But again, it comes back to the circumstances that we provide for people in labor. Yeah, it's just not, it's not fair, really, that we expect people to have a physiological labor birth in those circumstances.
Yeah, I agree. And there's not only oxytocin that happens in the brain. So what other hormones originate in the brain that contribute to labor function?
Yeah, so again, some of these things are not that well researched, but as I said, oxytocin in the brain has these widespread neuromodulating effects. And it was very interesting, actually. In some of the studies that we've looked at, and we haven't published this yet, we actually looked at oxytocin levels in relation to prostaglandins. And some of the studies that we looked at, it looked like women go through normal labor and birth without necessarily getting elevations in oxytocin. And that was true in some of the prostaglandin studies, which is quite concerning. It's not a final statement on anything, but it was kind of, interesting, and we may get around to publishing that paper eventually. So there may be another pathway through the parasympathetic nervous system that activates the uterine contraction. So oxytocin in the brain, as I said, it has a secondary effect on the that endorphins in the brain, so catalyzes or activates the altered state of consciousness, intrinsic pain relief, those things as well. But there's something else that happens. And again, we've seen it in some animal studies, but again, hard to measure in women. But I write about this quite well in the hormonal physiology report. So there seems to be something happening in women's physiology, or we say neuropsychosocial process at transition. So it's interesting, we call it transition, right? A woman's in this transition from one physiology to another. And often if you've seen women in physiological birth, you'll notice this, and it's something Michelle O'Donnell talked about a lot, which is when the pushing stage kicks in, women can get this surge of energy. They can be upright, which is the best position to push from, right? They can get this surge of energy to push their baby out. And they can have like involuntary contractions, like your body's not pushing, you're not actually deliberately pushing, your body's pushing. I was really interested in this when I had my babies, because I had such that experience with my first baby. They call it the fetus ejection reflex, right? I would have stopped pushing if I could, but my baby was just coming. It was a bit like, excuse the analogy, vomiting. Like you can't stop it. It's just coming, right? So my baby came very quickly in that first labor. But yeah, so what we think is happening there is, on top of the surge of oxytocin that we described with the positive feedback loop, the Ferguson reflex is going very strongly because of the very strong contractions and the very strong sensations, as you may have noticed in the pushing stage, right? So we've got the Ferguson reflex happening. But then what we think happens is there's a surge of adrenaline and noradrenaline. And at very high levels, at low levels, these inhibit contractions, which is part of that sense of safety, right? If the female doesn't feel safe and she gets a surge of adrenaline, that can slow or even stop labor. And studies have actually been done in women measuring their adrenaline levels in labor, and the higher the adrenaline early labor, the longer the labor was. Actually, the more adverse fetal heart rate patterns the baby had, so the more signs the baby didn't have blood and oxygen. So adrenaline in early labor can slow or stop labor down in some circumstances, and this is a bit unfortunate. They actually gave adrenaline to women in labor, and it caused stronger but uncoordinated contraction. So that can happen as well, yeah. So the adrenaline and noradrenaline surge at the transition stage, when levels get very high, instead of inhibiting contractions, it can actually promote contractions. So that process of promoting contractions is part of what has been called the fetus ejection reflex. So the fetus ejection reflex ensures, and again, going back to our evolutionary model, the mum is in the wild, she's in the pushing stage. The pushing stage is when she's most vulnerable, when she's least able to do fight or flight. So it's critical that pushing stage is as efficient as possible. And we think that, well, my opinion is, and you can read my opinion in the hormonal physiology report, my opinion is that the fetus ejection reflex is actually, we're not even meant to have a second stage. We're meant to have a fetus ejection reflex and push our babies out quickly and involuntarily. But I think personally, my own opinion is that depends on being undisturbed in early labor. If you start disturbing in early labor, it's hard to get the fetus ejection reflex. So yeah, that's the fetus ejection reflex. So that's a surge of adrenaline and noradrenaline. And then, it gives the mother that energy, that upright stance, the wide eyes often. And then after the baby comes out, those levels subside very quickly. And you'll notice that usually what happens is women start off upright when they're pushing their baby out, and then they gradually lie down lower and lower and lower. And that's kind of a marker of their catecholamines, of their adrenaline, noradrenaline levels. They're getting those levels are subsiding. They're getting more, we could say, parasympathetic. They're lying down, the oxytocin's coming in, and a whole lot of other things are happening in that hour after birth that we can talk about. So what personally I think is that oxytocin, opioids in the brain, but also this kick of adrenaline and noradrenaline, I think that's our evolutionary blueprint for the fastest labor and birth possible. I think we're designed to have a fetus ejection reflex, push our babies out quickly and easily in the wild. And then what's really important after that is that levels come down quickly, because if levels stay up, it's going to go back to inhibiting contraction. So, that hour after birth, it's critical again that the woman feels safe. If you want to because levels have to come down, oxytocin has to become predominant after birth to make her uterus contract and prevent bleeding. So if a woman doesn't feel safe, or even some people would say feels cold, which is a stress, after birth, that could increase the chance of postpartum hemorrhage. And it was an interesting study. I was really interested in this a few years ago. An interesting study done in the UK that actually looked at postpartum hemorrhage rates by individual practitioners. And some practitioners had high rates of postpartum hemorrhage in the women they attended, and some had low rates. And I would say that is, the atmosphere, the stress that they're creating after the birth. So it's really, really important, more important than ever, that the person who's just given birth feels private and safe and unobserved after their baby's born. And that's one of the skills of a midwife, right? In a home birth is you're there, but you're not interfering. And I loved at my home birth where my caregivers went into the room next door, and listened, but they were filling in all their charts and we were there just there with our baby. It was just divine.
It's so interesting you say that, because that is exactly what happens in physiological birth as I observe it as a home birth midwife, is women get this surge of energy and the adrenaline, which I believe gives them power to bring their babies out, the power that they need to bring their babies out. And then there's a gap in contractions, and then the contractions start again for placental birth. And so you're saying that's explained by the increase in adrenaline and then a rapid drop in adrenaline afterwards, which reinitiates the opportunity for oxytocin to act on the uterus for placental birth. Would that be?
That makes sense. That totally makes sense. As I said, we haven't measured it. I haven't seen adrenaline measured after the birth in the mother. I don't know. As you say, it's very important that the oxytocin being released there is not antagonized by adrenaline and noradrenaline, and that transition does happen quickly, as observed, for the mother, but also for the baby. We haven't talked about the baby, but the baby has this huge outpouring of adrenaline and noradrenaline in labor. It's called the fetal catecholamine surge, and the levels are high enough that will give a stroke in an adult, like enormous levels. And we talked a bit about how mammalian babies are superbly adapted to the contractions of labor and the hypoxia, and then the replenishment, and the hypoxia and the replenishment. And one of these mechanisms is the surge of adrenaline. The baby gets in the uterus, the more pressure on the head, the more hypoxia. Both of those things trigger this outpouring of adrenaline and noradrenaline. So that does all these things of making sure that the baby's brain and heart are always well supplied with blood and oxygen. It preferentially directs blood flow. And it also, the catecholamine surge also prepares the baby, so it protects the baby at that time. And it also increases the brain's ability to use glucose at low oxygen levels, anaerobic glycolysis. So again, protecting the brain and the heart. But also, at that time in labor, when the contractions are that strong and the baby's head's getting squashed and so hypoxic, obviously the baby's going to be born. So it's preparing the baby for life outside the womb on every level. Like it's activating the baby's metabolic system, like it's increasing glucose storage, increasing blood glucose level. It's starting to activate the brown fat in the baby so the baby can make their own heat after birth. It's also preparing the baby's lungs because, from life inside the womb to life outside the womb, this huge transition, the first thing that has to kick in is breathing. The baby has to breathe. And in the womb, the lungs are full of liquid, yeah. So the catecholamine surge is clearing the lungs of liquid. It's also opening up the airways. It's increasing surfactant, which is the lung lubricant, and all of these things preparing the baby to take the first breath, yeah. So the catecholamine surge, and the babies that are born with a catecholamine surge, if you look at pictures of newborn babies, they're so wide-eyed and alert. That's because of the catecholamine surge. And then the babies that don't get this, the pre-labor cesarean babies particularly, tend to be drowsy. I always think pre-labor cesarean is a bit like someone coming into your bedroom in the middle of the night and pulling the bedclothes off and shining this bright light in your eyes, and you're just not ready to wake up, right? You're not in that cycle of waking up. So, when the baby is not ready to wake up, it's quite a shock. But the baby who's been through labor and birth is superbly designed, well prepared for life outside the womb, including the catecholamine surge. But again, we want the catecholamine levels to come down quickly for the baby for a different reason. It's actually because the catecholamines are what I call metabolically expensive. So the mother has to reduce her catecholamines in that early period after the birth. The baby has to reduce its catecholamines in that early period after birth. So what happens is oxytocin, those peaks of oxytocin for the mother and the baby at that moment of birth, but with skin-to-skin contact, the mother's oxytocin levels can go up even 10 times higher than they were at birth. So it's very important. This is the magic of skin-to-skin contact after birth. It soothes the mother, it soothes the baby, it shifts them both from that sympathetic catecholamine surge into the oxytocin, pro-social, rest and digestive system. And as the catecholamine levels come down, the baby's still alert, but it's got enough oxytocin, or peaks of oxytocin actually, to be in this perfect state to initiate breastfeeding and bonding and do the breast crawl. So the baby's got this window, I'm sure you've observed it yourself, where the baby's alert and does all these things, and then the baby kind of goes to sleep or rest because the adrenaline levels are worn off. And that window of opportunity, we call it the early sensitive period, in that hour after birth, is critical for the mother and the baby to initiate these essential processes of lactation, of breastfeeding, and of bonding, of forming that relationship with the mother. And the wide-eyed, alert baby that kind of draws your pupils, the mother and the baby look at each other because of those high adrenaline levels as well.
Yeah, so really protecting that hour after and making sure you take advantage of the wiring that's set up.
Yes, exactly.
And you made reference to the fetal ejection reflex and also the Ferguson reflex. And I've heard people in the past talk about these as two separate things. Can you speak to that? Is the fetal ejection reflex and the Ferguson reflex the same thing or two different phenomena?
Well, there's different opinions about that. And to be honest, there's not academic things written about the fetal ejection reflex. When there is, sometimes it is correlated with oxytocin, because oxytocin generally is associated with those ejection reflexes, like the milk ejection reflex, the sperm ejection reflex. Those are oxytocin. So I think when it was called the fetus ejection reflex, I suspect that was to do with the oxytocin aspect of it. But what we think, and again, this hasn't really been studied academically, the fetal ejection reflex. So personally, my belief is that you get the high levels of oxytocin, but on top of that, all of those things we've talked about with the catecholamines. So I think the fetus ejection reflex is actually both of those things. I don't think that oxytocin peaks by themselves are enough to give that involuntary pushing. Personally, that's my own opinion. But yeah, as I said, I haven't seen academic things written about it. But there's quite a section on that of my own opinions in my hormonal physiology report. Yeah.
I had one more question. I wondered if it was possible to have pathology, innate pathology, not pathology that was influenced by external factors, but an internal pathology within the woman's body in that oxytocin system from the limbic system and how the oxytocin would flow through the body. Do we know anything about possible pathology that happens along that pathway that would inhibit birth, even in the most ideal circumstances?
That's a really good question, and there's not a straight answer to that. I'll tell you my own opinion. There are some circumstances that may make women less sensitive to oxytocin, and this is research done looking at women's sensitivity to synthetic oxytocin, which may be a bit different. We don't know for sure. But it seems like some women are less sensitive to it. Maybe women that are in the more extreme BMIs, like obesity, may be less sensitive to it. But I don't know whether that's a direct effect, a direct hormonal effect, whether there's something else going on for those women. Women that have had a bad sexual experience, for example, in the past, you'd expect that they wouldn't feel safe enough for their oxytocin system to flow. And there certainly is a propensity in the research to look for epigenetic causes of things. So people are looking at oxytocin receptors and oxytocin receptor differences. And there are some differences, for example, in parenting, in different variants of different receptors, et cetera, et cetera. So there may be small differences. But personally, I believe that because of the evolutionary necessity of reproduction, I don't think those things are actually going to stop us from giving birth, number one. And number two, if there is less sensitivity, then the answer is the same. We provide the circumstances that optimize the oxytocin system. If they're more sensitive, then we need to give them more support for their physiology. So I guess those are my two perspectives. And we don't, these things haven't really been researched as well. But I will mention one thing. This is not to do with birth so much, but it was a whole series of animal studies, cross-fostering studies, and it's to do with oxytocin. So they selectively bred rats to give high levels of maternal care or low levels of maternal care. These weren't like genetically altered. They were like selectively bred. They got the worst mothers and they bred them with more worse mothers, etc. Right? So there's two different types of rats here. And then they cross-fostered. So the mothers that were giving high maternal care naturally looked after the babies bred to give low maternal care. And then they looked at the female babies, offspring, how they mothered. And when they'd been given high levels of maternal care, even though they were bred to give low levels, they gave high levels of maternal care to their babies. And it actually changed their oxytocin systems. It changed, anyway, a bit complicated, but the estrogen receptors in the brain that upregulated the oxytocin were more sensitive. So they released more oxytocin from those high levels of maternal care. So some of these things, personally, I think can also be behavioral, can be from previous experiences as well. Yeah, personally, I think that previous experience in labour and birth is important to activate those things. And there may be previous good experiences of labour and birth or previous good experiences of mothering could influence the system. I'm saying that based on those studies. But again, the take-home message is if you've got an insensitive system, support it. Yeah.
Yes. Okay, I have one last question. And this is, and you may or may not have the answer at the top of your head, but during your PhD that you're currently still in the middle of writing, is there anything that you learned that surprised you, that was brand new and you thought, whoa, I've never heard that before?
I think what surprised me in all of this, and including writing the hormonal physiology report, I think what surprised me and was very satisfying to learn actually was those shifts in the maternal brain that we talked about. And the reason it was so satisfying to learn is because that was so my own experience with my first baby, Melanie. Like I had my first baby at home in Melbourne, and my neighbour was a mother of 3, and she lent me this bassinet. I had the nursery set up, like I was going to do this particular thing with my baby. And then I had this beautiful, short and sweet labour at home. I held my baby in my arms, and no way would I have my baby further than an arm's length away. And I could literally feel through those 5 hours of labour that my brain had shifted. It had gone 180 degrees from the direction that I was heading in. And what was so interesting in all of this research really is to see how that actually, what we know about the brain in the shifts that happen in labour and birth, and the importance of it, how necessary it is for survival of the species. And then, that subjective experience of my own brain shifting. Yeah.
I've had clients reflect that they also had a similar experience. They felt their brain and psyche and just perspective shift almost instantaneously after birth. And the disappointment that they felt that everybody around them wasn't having that same experience. They were ready to kind of change their lives and do all these new things based on their new brain. And they were just disappointed that nobody else was in that mindset to go with them on that.
Well, there's changes in the paternal brain, but one thing to add about that, which is there is some hormonal support for that. So this was actually a rat study. So they've got 2 rats in a cage, and they inject 1 rat in the brain with synthetic oxytocin. So that rat had the pain relieving effects. They could test that, but its untreated cage mate also had those pain relieving effects. And they figured out that it was actually transmitted from one rat to another through the vomeronasal organ in the nose, like a pheromone. And what that means, my interpretation of that is that when you're with someone with these high levels of oxytocin, then you get that to some extent too. Like as a midwife, you get a bit addicted to birth. It's very rewarding. You can get that euphoria. And I actually think that is designed to change the brains to some extent of the people that are there, and to support in humans, we do alloparenting. We look after each other's babies, the father being present, the other midwives, the grandmothers being present, or everyone to some extent will get some oxytocin and get some brain shift that will help them to take care of that baby and enhance survival of the species.
Well, we talk about oxytocin being contagious, and that also really speaks to the social element where historically women were surrounded by the other women in their community and the village midwife who, I guess, would, by the contagious nature of oxytocin, be interested and invested in caring for this baby as well as part of the community.
Exactly. It takes a village.
Yeah. Thanks so much, Sarah. That was a lot of amazing information. Are there any final things that you feel like we need to share in regards to the interaction of the brain and the body during labour and birth?
Yeah, I think the most important take-home message, and I hope it's come through to some extent, is really to pay attention to the circumstances and the caregivers and who you have in your space. And I guess my parting advice would be that the processes of having a baby are very similar to the processes of making a baby. So when you're looking at what you're lining up for your birth, is that somewhere where you could make a baby, and how can you make it more conducive to that kind of activity, because that's going to be the place that's going to be easiest to have your baby.
It's an amazing way to wrap up. Thank you so much, Sarah. And I will see you at the Convergence of Rebellious Midwives in
so excited for that. Thank you, Melanie. It's a pleasure.
To get free access to all the research that's used to create each podcast episode, you can join the mailing list at melaniethemidwife.com. or you can join our members hub and financially support the work of this podcast. In the hub, you can ask me questions, and premium members get access to a monthly Q&A episode where I answer listener questions. You'll also get episode transcripts and additional resources for each podcast episode. All the details are in the show notes.